I'm Dan Belnap from the Legal Action Center. To begin, to tell you a little bit about the Legal Action Center, we advocate on behalf of people with addiction histories, criminal records, and HIV/AIDS. We have offices in New York City, where we're based, and Washington, D.C., where I'm based. In D.C., we work primarily on the federal level to expand services and reduce barriers for the people that we serve. And I specifically work on health policy as it relates to expanding access to coverage for coverage and services for people with substance use and mental health disorders. The Legal Action Center also serves as the co-chair of the Coalition for Whole Health, a coalition of over 100 national, state, and local member advocacy organizations who are advocating for strong implementation of the Affordable Care Act for mental health and substance use disorders. Today I'm going to talk a little bit about updates on work that we have been doing on the national level, next steps for our advocacy, ACA implementation related to the essential health benefits, the benefits that, including mental health and substance use disorder benefits, that will impact the health coverage of over 70 million Americans who are getting their health coverage through the small group and individual market, as well as beneficiaries in Medicaid benchmark plans. I will talk about the specific work of the Coalition for Whole Health and the work that we have been doing related to the Essential Health Benefits Package. I will talk about the ongoing implementation of other important provisions in the Affordable Care Act, and I will talk about the huge need for advocacy right now and how you can stay involved as we work with policymakers to ensure the strongest possible implementation of the health care reform law for people with mental health and substance use disorders. To take a step back, over the past few years, the past 4 years or so, we have really seen some tremendous change in healthcare policy related to mental health and substance use disorders. The Mental Health Parity and Addiction Equity Act, the Parity Law, was passed in 2008, and with healthcare reform in 2010, and ongoing implementation of both laws, we have seen a greater understanding of addiction and mental illness as treatable chronic health conditions. We have seen addiction and mental health prevention, treatment, recovery support services, and providers being brought into the broader healthcare system, both in terms of policy implementation as well as partnering on the ground with providers and primary care integration. And moving forward, we are anticipating a dramatic expansion of coverage of addiction and mental health care through the new federal parity and health care reform laws, the Affordable Care Act, or the ACA. Okay, so let's talk a little bit first about essential health benefits. Essential health benefits are one of the most important provisions in the law for individuals with mental health and substance use disorders. It's a very important consumer protection. The federal government is paying a lot of money for health care reform, and they want to make sure that they are getting their money's worth. So there is a minimum set of benefits that must be provided to enrollees of certain health plans. So beginning in 2014, the Affordable Care Act will require certain health coverage to meet minimum requirements, including these benefit requirements. And outlined in the law are 10 categories of services that certain plans will have to cover. Those are ambulatory services, emergency services, maternity and newborn care, mental health and substance use disorder services. Again, that must be covered under certain plans. Hospitalization, prescription drugs, rehabilitative and habilitative services and devices, laboratory services, preventive and wellness services, and chronic disease management, and pediatric services. And it's important to note that while the mental health and substance use disorder requirement is by itself extremely important, our services, these diseases really fit into most, if not all, of these 10 categories. Okay, so let's talk a little bit about where the EHB, the Essential Health Benefits Package, applies, essential health benefits, these 10 service categories, have to be provided by private insurance plans participating in the health insurance exchanges, these new marketplaces that will be state-based where people from the individuals and those in the small group health insurance market will be purchasing coverage. It will also, the essential health benefits will also be required by non-grandfathered individual and small group plans operating outside of the exchanges, and it will apply to newly eligible Medicaid enrollees, including childless adults who will become eligible in 2014 for the first time in many states, including Maryland. Okay, so it's important to note that the essential health benefits package does not apply to traditional Medicaid and to large group plans. Large group plans and traditional Medicaid do not need to meet the essential health benefits requirements. The essential health benefits package will directly impact over 70 million Americans, and where the essential health benefits package is required, parity is required. So the ACA improves on the federal parity law that was passed in 2008 to, first of all, require mental health and substance use disorder services that the parity law did not do, and extend the parity requirements to the individual and small group plans. The original parity law only applied to large group plans, and it said that only if those plans provided coverage for mental health and substance use disorders, only then would they be required to cover them at parity. Okay, so that's what's in the statute. And now as we're moving on to implementation of the law and regulations, these decisions are really being made right now. So the 10 categories are in statute. The healthcare reform law leaves it up to the Secretary of the Department of Health and Human Services to define what exactly those essential health benefits means, what that package means. So on December 16th of last year, HHS released a bulletin outlining their proposed approach for defining essential health benefits. And in that bulletin, they indicated that there would be a strong state role and no federal definition of essential health benefits. Instead, the Secretary is allowing states to benchmark to one of 10 options in that state. States will have the choice to benchmark plans to base their essential health benefits package on the benefits offered in their choice of one of the 3 largest small group plans in the state, one of the 3 largest plans available to federal employees, the Federal Employee Health Benefits Plan, one of the 3 largest state employee plans, the largest HMO in the state, so those 10. And for states that do not choose one of these 10 benchmark options, the default plan will be the largest small group plan in the state. Okay, so what does all of this mean? We know that states will have a lot of flexibility to define the essential health benefits package. There will be some range and variability in the mental health and substance use disorder benefits that are available in a typical employer plan. We have done some analysis, and others have done analysis that shows that for the most part, in employer plans, there is relatively broad coverage. However, for the full continuum of mental health and substance use disorder services in existing plans, and we know that the essential health benefits package, whatever states decide, the mental health and substance use disorder benefits have to be consistent with parity. So they have to be at parity with the medical and surgical benefits offered in that plan. And we also know that non-discrimination requirements of the ACA will also apply. We also know that mental health and substance use disorder benefits, because of the parity requirements and the structure of the benchmarking process, we know that they appear to be protected against weakening by any substitutions that may be allowed. And we know, really, the bottom line is that state-level advocates are in a strong position to influence the essential health benefits package, and advocacy at this point is extremely important. Okay, so let's talk about some of the tools real quickly. I mentioned the Coalition for Whole Health earlier. It is a coalition of all of the major national mental health and substance use disorder advocacy organizations. We also have state and local organizations who are affiliated with the coalition. And as a coalition, the mental health and substance use disorder fields have come together to advocate for strong mental health and substance use disorder benefits and to develop specific health benefit recommendations. So we have developed a consensus document that talks about the essential health benefits and how they need to address long-term recovery as a chronic care approach, include prevention, treatment, habilitation, and rehabilitation, prescription medications when appropriate, and the full continuum of mental health and substance use disorder care. More specifically, the consensus document developed by the coalition includes recommendations for a minimum benefit package that would be acceptable for mental health and substance use disorders. That includes outpatient treatment and intensive outpatient treatment, inpatient hospital services, residential addiction treatment corresponding to ASAM Level 3, prescription drugs, including all approved medications for mental health and substance use disorders, pediatric mental health and substance use disorder services, mental health and substance use disorder related prevention and wellness services, and mental health and substance use disorder chronic disease management services and supports. And there is more detail about what exactly these benefits are, and including those organizations that have signed on to the recommendations of the Coalition for Whole Health. It's available on the coalition's website, coalitionforwholehealth.org, and I really encourage you out there as advocates for the people that we serve to check out the document and use it as in a tool as you work to evaluate benchmark options and what the state is deciding on these important decisions that will impact so many people. Okay, so just a quick note on some other important activities related to implementation of the Affordable Care Act, the Medicaid expansion, and Kevin will talk a little bit more about this in a minute. Medicaid expands coverage to everyone below 133% of poverty, including childless adults. Across the country, that's expected to result in about 16 million new Medicaid enrollees, and about 250,000 of those will be in Maryland. States will also be deciding the benefits for the Medicaid expansion, and they will be doing it in a similar way to the process that they are using to define benefits for the exchange and small and individual group qualified health plans. It will be a little bit different, but they will be also benchmarking against private plans in a similar way. And it's important to note that the Medicaid expansion must meet the essential health benefits categories, meaning they must include mental health and substance use disorder services, as well as the 9 other essential health benefit categories of services. They must also meet parity requirements for this Medicaid benchmark population. And it's also important to note that the federal government is paying an enhanced match, including 100% of the cost of covering these new enrollees for the first 3 years of healthcare reform implementation. Okay, and we're also paying close attention to implementation of the health insurance exchanges. Again, these are competitive state-based marketplaces for small group plans and individuals to pool risk and purchase insurance. These plans will all have to meet essential health benefits requirements and parity requirements, as well as other consumer protections. And it's also important to note that plans participating in the exchanges will have to maintain a sufficient network of providers, including mental health and substance use disorder providers, to ensure that all services are accessible without unreasonable delay. And in the regulations, it was specifically mentioned that HHS is expecting a large increase in demand for these services when healthcare reform really begins to kick in 2014, and they were concerned that there would not be the sufficient number of providers to meet that demand. So plans will have to contract with providers to make sure that will happen. And again, some other important activities that we're paying attention to: integrated care initiatives, including health homes and accountable care organizations, inclusion of substance use prevention in the chronic disease prevention initiatives, identification of the addiction service workforce as part of the health workforce. So that's ACA. I'm going to talk real quickly, and my time is wrapping up, about the need, as we're going through all of this, to protect the substance use disorder safety net funding, particularly the substance abuse prevention and treatment block grant. We know that that healthcare reform coverage, these provisions do not kick in until 2014, and it'll take years to fully implement all of these provisions and cover the people who need the services with the services that are currently being defined. Now, we don't know what those services will be at this point, and there is a huge need for continued strong federal funding for the prevention, treatment, and recovery supports before the ACA is fully implemented and beyond. And we know that the essential health benefits package that we're all working on won't include all of the services that everybody needs, and we also know that the provisions of the Affordable Care Act will not cover everyone. So there will still be people who fall through the cracks, and the block grant, protection of the block grant and that funding is critically important now, and it will remain critically important in the future. Finally, we as a national drug and alcohol community are really fighting for strong continued safety net funding, the highest possible funding for SAMHSA and the continuum of addiction and mental health services. And there is a huge need for a continued push around the country with Congress and with the Obama administration to make sure that all of these great provisions in the law are fully implemented in the best possible way, and that the safety net is protected and people are able to get the services that they need to get in and stay well. So finally, my last slide: continued outreach and education within our field, outside our field, with our partners in the broader healthcare community, connecting our work in Washington with the implementation efforts that's going around the country and here in Maryland, speaking with one cohesive voice and finding the best ways to engage our champions to ensure the strongest possible addiction and mental health benefits through healthcare reform, protecting the safety net, and monitoring implementation and informing our federal partners about successes as well as non-compliance, so the enforcement can take place. So that's it, and I will turn it over to Kevin.
Thank you very much, Dan. Thank you very much. My name is Kevin Malone. I work in the Administrator's Office of Policy Planning and Innovation at the Substance Abuse and Mental Health Services Administration, which is an operating division of the U.S. Department of Health and Human Services. All that can be broken down into fun acronyms, as I'm sure you all know. For those of you who are unfamiliar with SAMHSA, we are responsible for supporting the substance abuse treatment and prevention, as well as mental health service system in the United States. It's an honor for me to be here and speak with you today. I have been asked to provide a sort of basic overview of how SAMHSA sees health reform and its implications for substance abuse treatment providers in Maryland. There's a lot of information available out there about the Affordable Care Act. Dan gave a very good presentation on a few very important components of the Affordable Care Act related to the benefit package that will be covered for that will be available for individuals in Maryland with regards to substance abuse treatment. So I want to speak in very general terms, both about sort of what we think substance abuse treatment provider organizations should be thinking about, focusing on in their planning over the next couple of years, because like was said in the introduction, substance abuse treatment providers are facing some of the most sweeping changes in their clinical and business practices as a result of the Affordable Care Act. Bill will speak, I think, much more eloquently than I about the changes in clinical practice that many substance abuse treatment providers can expect. But I want to speak in general terms about, particularly around business practice, what substance abuse treatment providers should expect and can start planning for, as well as some resources that SAMHSA is hoping to make available to substance abuse treatment providers through these tumultuous times. So in general, as Dan indicated, the benefit package for substance abuse treatment coverage is going to be significantly different than it has been in the past. Maryland is lucky in the sense that Medicaid has provided a substance abuse treatment benefit historically, though not necessarily the most generous one. That should get better in the future, and as a result, the opportunities for substance abuse treatment providers should definitely improve. Though the theme that for provider organizations, particularly substance abuse treatment provider organizations, that I want to drive home is that there's both opportunity and challenge in the Affordable Care Act. There will be significantly more potential clients who will have coverage through either the health insurance exchanges or Medicaid, and but at the same time, many of the financing for those services is more likely to be through private health insurance companies or through managed care contracts. And from a business practice perspective, there will be less direct contracting with the state. More skills will be necessary on your part to do third-party contract negotiation, third-party billing. Your compliance practices will have to improve. Your adoption of health information technology will definitely need to go through a significant change in order to participate in this expanded market. So we understand that those are both challenges, but we also want to emphasize that the incredible work that the advocacy community has done over the last 4 years cannot be overstated. The expansion in coverage, the expansion in the benefit package really will bring, by our estimates, more than 11 million new individuals into the health insurance market who currently have substance use or mental health issues for the first time, who are currently uninsured. So the opportunity is great, and I encourage you to go to SAMHSA's website, www.samhsa.gov. There's a subpage on health reform that has significant resources. There's a whole series of webinars that are less rushed than our presentation today, with considerable information around the essential health benefit that you can go through again and again and again. And please look forward there more for more resources around particularly assisting providers in overhauling their business practices and making sure that you are in a position to compete on an even playing field with other providers in your other types of providers, and participate in the new healthcare world. One last thing I want to emphasize is that there's a project going on with peer and recovery community organizations led by SAMHSA to help develop a coalition of peer and consumer organizations at the state level around work on the essential health benefit to really spread knowledge and information, as well as work around eligibility and enrollment. The history of eligibility and application processes for Medicaid is a tragic one, and I understand in Maryland that the application process still takes quite a while for a determination to come through. The Affordable Care Act will change that entirely. the application process should happen in a real-time basis, and we are hoping to work through some of these projects to help peer and recovery community organizations really be engaged, as well as provider associate organizations like yourselves, in the enrollment assistance process. So the lead organization for this coalition of peer and recovery community organizations in Maryland is called On Our Own of Maryland Incorporated. They were just notified of this last week, so they're probably still getting their plans together. But please look forward in the future to a coalition in Maryland being developed around spreading information on these issues. So please feel free to contact us at SAMHSA if you have further questions, if there's particular things you would like help with. We are here to help you. So thank you very much. I'll turn it over to Bill.
Thank you, Kevin. I'm Bill Reedy. I'm a clinical social worker, currently working with the National Association of Community Health Centers, which is the national advocacy organization representing the over 1,200 community health centers, federally qualified community health centers around the country. Collectively, community health centers now serve upwards of 20 million people. A good proportion of them have no insurance and treating many people with Medicaid and other sources of payment. What I'm going to talk with you today about is just to give a few thoughts on the opportunities that all of this change is occasioning for you. And I guess change, as we know from what's been said so far, and as you know from your daily life, is the key characteristic of what's going on. So there's lots of unknowns and uncertainties about how the law will play out, how implementation processes will play out. But what's of prime importance to remember is that indeed change is underway and is not likely to stop. And the change that I'm talking about is the change in the design of the healthcare system. It's going at a feverish pace right now that you probably are well aware of. And it offers enormous benefits to all of us in terms of our experience as being consumers of healthcare, which we all are. The number one problem we've faced for so many years and are still struggling with is the fragmentation of healthcare. That's kind of the source of much of our inefficiency. It challenges the opportunity to give quality. It makes it harder to give good quality, consistent care over time. And it makes an experience that can be miserable for consumers and patients at various times when they have to be kind of the navigator and of their own healthcare, organizing it themselves through a system that's very hard to discern, and many transitions and bridges that have to be crossed with no knowledge or other connectivity about their previous healthcare experience going with them. So there's an enormous opportunity that's and reality that's taking place that this healthcare system is changing. From the perspective of substance use and behavioral health conditions, it is also an incredible opportunity because, as we know right now, the way things currently are, a very small fraction of the people who need services for substance use related disorders actually connect with them, get them, and complete care. All of the tangled web of connections that need to be made around payment and just finding services, and then when you find service, being able to get access to the service, it can just be a maze for people to navigate. So the good news then is that with the opportunities from the perspectives of the community health centers, which is what I'm going to talk a little bit about, there is an increasing interest and need to partner with substance use providers and agencies to better care for the needs of the people that they see every day. The reality is that most people have contact with healthcare, and the people who have substance problems have many other problems as well, many other medical problems that are complicated terrifically and is directly related to substance use disorders. So as the healthcare system and again the community health centers and the FQHCs strive to improve outcomes for patients and achieve better, efficient care with better outcomes, it becomes increasingly important to pay attention to the substance use and other behavioral health disorders that people may experience. Having said something about the opportunity, I guess I'll just say a couple of things. I'm going to skip over some of my slides here. I'm going to say a couple of things about what the transformation is all about and what the experience on the ground is from health centers' point of view. We hear the term a lot, patient-centered medical home, person-centered medical home, health homes, and we may not always fully recognize the full impact of what this transformation is that's going on in healthcare practice. Person-centered care. It aligns very nicely with kind of the recovery orientation that has grown up and developed in the substance use field, building and supporting recovery. It relates wonderfully to the need to empower people, to help give them supportive services to manage, to be partners in their care, and to give them tools and resources to support their own self-management of their health and take charge of their health. The aspects of the way care is transforming, if you're on the ground in a health center, you're starting to recognize that rather than kind of moving from incidents of particular treatment that's dispensed, it's increasingly a transition towards a more population-based focus of care, meaning that in person-centered medical homes and other such configurations, the process of care is being transformed, meaning that the care team is developed so that there is an interdisciplinary care team that's engaged to be responsible for the health of a particular specific population of patients. And so as the health home forms or the medical home forms, the team gets to know it's important, it's imperative for the team to be proactively seeking out to understand what the needs and concerns and issues are of the population they're caring for, to make sure they have the right team assembled to address those needs, and then to proactively kind of reach out and address and work on these problems over time, and to maintain a continuous healing relationship with specific folks in their practice that manages and coordinates their care systematically over time and across the continuum of care, so that the services that are needed to address fully the health concerns they have are taken care of, and that the outcomes of the individual are improved in terms of quality of life and specific health outcomes. That having been said, there's a real retooling in order to take advantage of the opportunities to partner with health centers. It's important to think about kind of the skills that you have as substance use providers and how you can kind of retool and rework and kind of develop the additional tools you're going to need to work in these other settings. The opportunities, probably I can't give you a straight list of them, but I guess I can tell you from having talked to many health centers, there is a regularly expressed need to be able to secure better access to specialty addiction services when they're needed. I hear this over and over again, is that when problems are identified that are needing services, when an individual needs services that are beyond the scope of what can be done in a primary practice in a health center, it's often difficult to access and find those resources. So there is an eagerness on health centers' part to partner with all of the services that are needed by their patients, to connect with the community resources, and to develop relationships and ways of integrating care together that will create a good experience for the person who needs the services, a smooth, seamless transition across the various systems of care and programs, and a continuous planful effort to work on one treatment plan that addresses the whole needs of the person. So that having been said, the needs that the substance use community needs to think about are how to be able to work to coordinate, to understand the demands in primary care, to kind of adjust their practice that are suited to this different environment, help in the identification of high-risk high-risk individuals who have particular needs, to become really conversant on skills such as the stages of change, procrastinus and De Clementi's kind of stages of change work, to kind of help work on teams to help meet consumers, patients, people where they are, and use techniques such as motivational interviewing and other kinds of skills to engage with folks, to start to plan and move people gradually from where they are, to help them, empower them to kind of take the steps they need to take charge of their health and address their substance problems. There's very specific skills around screening, brief intervention, and referral and treatment, care coordination across the continuum. And there's actually unique opportunities also in community health settings, community health centers, to make available to patients various approaches in medication-assisted treatment that are available, increasingly available now. Some of the medications that have been of great use to and great benefit to help people in their recovery process. So I guess in sum, I would say that there are, with due reference to everything that's been said up to this point in the panel, it's important to pay attention to business processes to be able to, because it is going to be a different environment for contracting, for credentialing in terms of kind of the preparations of consumers or of the providers. There's also an important need to develop those additional skills and prepare yourselves to work in integrated care teams, integrated interdisciplinary care teams, and to be able to learn how to communicate more effectively with each other, building around the central concern to address the whole person's healthcare needs. And so at this point in time, and in addition to kind of preparing yourself, engaging in dialogue with your community health center and the primary care association in the state, to explore ways to be connected and to support each other. The trend towards person-centered medical homes is a trend, and is, I'd say, more than a trend, because there's an enormous transformation taking place, and it's publicly supported through the many Medicaid plans, Medicaid state initiatives. Managed care is taking this on and promoting it in a very strong way. So it's going to be it's a reality that is coming and will be upon us. The medical home needs a medical community to really attend to all of the needs, and substance use providers and the treatment services and support services that you offer are a crucial, important part of that community. So I would encourage you to, if you haven't begun the dialogue with and gotten to know your community health centers and their organizations, begin today. And I think it'll open up a whole world of opportunity to improve care and the quality of life and health for the people that we care about. Thank you.
Good morning. First and foremost, I'm going to speak about my experiences with the disease of addiction and my mental health disorder. For me, this is kind of different, but it's an honor for me to sit here on this panel, of advocates and people who fight on a daily basis for people that seek in recovery. I am one whom is in the recovery process as we speak, and coming into this process, me, myself, I was sent here originally through the judicial system. Basically, what worked for me is what we call a state baby. I was under the PAC program, which is the primary adult care program that I had taken advantage of, and as I stated before, I was sentenced to come into the recovery process through the way of a drug court judge, which is an alternative sentencing program in which I would do a recovery program to keep me from going to jail. Well, as I come through the recovery process, I liked it. It was something different for me, and I know that I was a better person. I just made some bad choices, that landed and ended me up in the situations that I put myself in. What worked for me in my process as far as the treatment aspect under the primary adult care system was basically the intensive outpatient groups that helped me, my therapist, my psychiatrist, my one-on-one sessions that I had with my doctor, my addictions counselor, and the maintenance of the medications that I needed for my mental disorder, because in the beginning I didn't think that I had one. But as staying here and being here, I came to believe that I did have a mental disorder as a direct result of my drug abuse. I'm a firm believer in building a foundation. And in building that foundation, I have acquired people who I know have my best interests at heart. And in coming around here and having trust issues with people in the beginning, I gave myself a chance. I gave myself a break. And I did something different. I came to believe that there was a power greater than myself that could help restore me to some type of sanity here in this recovery process, because I'm a firm believer in acquiring one. I am totally honored to be here on this panel today, in front of these advocates that help fight on a daily basis for people whom lack insurance, that's coming into the recovery process. Because for me, this is a life-changing experience. I wouldn't give it up for the world, The disease of addiction has taken me places I'd never, ever thought I would go. It made all my nevers come true, Being active in my own recovery. The disease of addiction, it starts with me and it ends with me. So today I make the right choices for myself, and in me building my foundation, I put people in my circle that's conducive to my recovery, like NCADD, the people whom I now work for, the National Council on Alcohol and Drug Dependence. I'm the coordinator of the Recovery Leadership Program there, and I advocate for recovery now. it's just an honor for me to be here. I just would like to thank everyone, you know, who on a daily basis, the many organizations fight for people in recovery. And thank you very much.